Okay, our next speaker is Dr. Paru King, who's going to talk about PROCEED, which is Preconception Care for Diabetes in Derby, a Teams Without Walls model. Paru.
Well, thank you. I'm going to talk to you about PROCEED as per Jonathan's kind introduction. I'm going to start by setting the scene by explaining why we chose to remodel our preconception care service and share with you some of our results that led to a Quality in Care Diabetes Award in 2012. But my main remit is to talk to you about what we've done since the award and how the award has helped us achieve our later goals. So this audience needs little introduction to the adverse outcomes of diabetes and pregnancy and the benefits of preconception care. So in my area, we serve a greater population of 600,000, handle 6,000 deliveries a year, 50 of whom have pre-existing diabetes. And at the time of the confidential inquiry into maternal and child health in 2002 and 2003, our outcomes were similar to the national average. Around a third of our women were seen before pregnancy. 1 in 10 women had a congenital abnormality, and our stillbirth rate ran between 4 to 6%. And our service was undertaken in an antenatal clinic environment, and our ladies were telling us that was often quite a stressful place to be seen. So we wondered whether we could take our service nearer to our ladies outside the hospital setting and provide a service that better met the user's needs. And we were fortunate in receiving funding from the Health Foundation to pilot PROCEED. This had 2 components. The first was raising awareness of the need for preconception care, and we did this by not only approaching the ladies themselves, but all professionals that were involved in the care of women with diabetes, encouraging them to use every opportunity to discuss pregnancy plans and contraception. Our care model can be summarised by 6 C's, as shown here. So working around them, we worked across organisational boundaries, taking into account all competent resources irrespective of location, which gave our ladies choice, not just in terms of location, but who they saw, where they were seen, and when they were contacted, and how they were contacted, telephone, email, as well as face-to-face. For each place that we provided a PROCEED service, we had a member of the antenatal team, so we could ensure consistency of information given, and when the woman then became pregnant, a seamless transfer of her care to the antenatal service without loss of continuity of care. And my role as a consultant physician changed. Instead of seeing everyone that came through the door, I concentrated on those at the highest risk, but provided mentorship and an overview to ensure the lean delivery of the service. So after 12 months, we were able to demonstrate improvements in quality in all 6 domains of quality improvement. So for example, we were able to show improvements in efficiency and productivity. So while we doubled the numbers, we were able to reduce failure to attend rates and waiting times. We improved outcomes, so we saw more women before they became pregnant and they were better prepared for pregnancy. We found that the congenital abnormality rate dropped to 4%, and in that year we saw no stillbirths. The ladies we looked after described the service as excellent and first class, and we were able to demonstrate £68,000 savings. So we won the Quality in Care Award in 2012 for the Best Improvement Programme in Pregnancy and Maternity. So the question is, where have we gone from there? So at that time, there were 3 areas of challenges that we saw. First was, as we reached the end of the funded period, would we be able to get the service commissioned and secure funding and demonstrate sustainability of our outcomes? The second, that happens when I'm sure when you've won awards here as well, that you do generate publicity, which is excellent. And we had a lot of interest in other centres who wanted to adopt our model. So the question was, how could we support adoption and spread most effectively? A third was an understanding that when we undertook our cost-saving analysis, that there were no UK costs for congenital abnormalities. And so the cost that we estimated was based on a single HRG code on admissions. And we felt that this didn't accurately reflect true cost savings, so we wanted to develop this further to result in a costing tool for congenital abnormalities. And we were fortunate to receive more funding from the Health Foundation to try and address each of these issues that I'll consider in turn. In terms of commissioning, we submitted a business case and we secured commissioning through our integrated care model for diabetes. And this graph looks at our outcome data. The far left-hand set of lines looks at the percentage of women that access preconception care, which is a preconception care rate. The middle set of bars, the congenital abnormality, and the right hand, the stillbirth rate. The purple bar represent the baseline 2002-3 data, and the other bars are the PROCEED data since 2011. And you can see that we have sustained the increase in the percentage of women that are accessing preconception care. Overall, around 2/3 of our ladies are seen before pregnancy. A congenital abnormality has reduced from 10% to 4%. And in terms of stillbirths, that's always difficult because the absolute number is low. But in a 4-year period, we've seen 2 stillbirths and 196 pregnancies, as compared with a 4 to 6% stillbirth rate before. So while you can't apply statistics, to me the trend is clear. In terms of adoption and spread, we had envisaged publishing a website to help people learn more about PROCEED. And in fact, we had initial discussions about this at the awards ceremony with Anna Wharton, the director of NHS Diabetes. And NHS Diabetes was going to support us to undertake this project. Unfortunately, that was not to be, as you know. So we were stuck for a while. But again, having won the Quality in Care Award meant that we had other contacts, this time the shape of Sanofi. And Becky Reeves signposted us to a web developer who had experience in working with NHS organisations. And we were able to write and publish a series of web pages. The website is shown on the slide here. That was aimed to inform commissioners, clinicians, and also people with diabetes about the work that we'd done and how we had achieved it. We also used every opportunity to share our practice, such as today, through presentations and workshops. And again, the award provided me with specific opportunities to share our learning through the QiC Connect website and through a webinar as well. One specific area that we looked at through the funding that we achieved was a feasibility study. You can share your learning, but what are the barriers and facilitators to actually spreading your project to another area? And we chose to work with Leeds and Eleanor Scott in particular. And we had a huge amount of learning in the year or so that we tried to spread aspects of PROCEED to Leeds. We learnt there's some things that you can't do anything about. So if the priorities of commissioning isn't there, then you have to wait till you're in the right place at the right time. But while you wait, you need a clinical champion who would look at every opportunity to achieve the goal that they want. And Eleanor was absolutely fantastic in this regard. And she eventually managed to work with the commissioners and secure a community-based preconception service, which was midwife-led. So it wasn't the original direction of travel that we envisaged, but we did achieve our goals. So the third area was the costing tool that I first mentioned. So just to remind you, there are surprisingly no UK costs for congenital abnormalities, and we used an HRG code looking at non-elective admissions for people with congenital abnormalities. Clearly that shows you snapshot data. It doesn't look at lifetime costs, and it doesn't look at social costs either. So we undertook a 3-centre audit, 2 centres in East Anglia and Derby, to define the types of congenital abnormalities that we're seeing. We then worked with a local health economist to take each of these abnormalities and the range of problems that you see. And I've shown you a couple of screenshots of 2 examples, spina bifida and congenital heart defects, to cost up the healthcare interventions, the healthcare costs, and potential social care costs. We then looked at the congenital abnormalities that we saw at baseline and in the PROCEED year, and looked at the children that were surviving and applied this costing tool. And we estimated that in that first year of PROCEED, the lifetime cost savings were £3.25 million from saving congenital abnormalities, compared with our original estimate of £7,000. So a massive difference. So I hope I've shown you what we have achieved in our first year of PROCEED, and also what we have subsequently achieved with the help of the award that we won. Thank you very much.